I'm talking about community because we have to recognize that long-term care is part of a continuum of services. There's a full context here. However, that being said, ARC is focused on long-term care. The reason for that is because we hope to ride the wave of public anger and grief about what happened in long-term care. The issues, of course, and we'll talk about that in a minute, the issues that occurred in long-term care during COVID were just exacerbations of long-standing structural and systemic issues. Action for Reform of Residential Care was formed after COVID started, and it's made up of clinicians, researchers, and family and people who have an interest in long-term care, either by working there or having a family member there. So very much grounded in the system one way or the other. We also are supported by a number of organizations. I think 45 organizations in BC support our work. By that, I mean the recommendations that we've made, because our key activity initially was to develop an analysis of the long-term care system in BC and make practical and concrete recommendations to the province for what needed to change. We wanted to, it should be next slide. Sorry. Can you move the slide, please, Laura? Thank you. And the next one. Thank you. Okay. So what we wanted to do, as I say, was to build on awareness. We wanted to give a full critique of the system, and we wanted to make our recommendations very practical, but we did want change. We wanted to see the residential care system actually reformed, not just moving the deck chairs in the Titanic by piecemeal approaches. We wanted to be advocates for vulnerable families, voiceless long-term care population, and also the staff, actually, that were working in long-term care. And we took the line of trying to support government and taking action on long-term care. Okay, could I have the next? Our focus was quality of life, and quality of life, there's been a fair bit of research on quality of life in long-term care as well as in community. And most recently, the work by Janice Keith in Nova Scotia, and with the pockets of research centers in different parts of the country. And prior to that, the work by Rosalie Kane. Quality of life, these are some of the things that we at ARC believe. Quality of life does require quality of care, that care is a relationship between those receiving care and providing care. And the quality of care is, of course, linked to quality working conditions, which has been said over and over already this morning. And you can have quality of care without quality of life, but you cannot have quality of life if you don't have quality of care. And quality of life requires a number of things. And first and foremost, people need to feel safe and secure in the environment they're living as individuals, right? Meaningful and sustainable relationships are extremely important, that sense of connection and mattering to people, that I matter. A sense of belonging, a sense of meaning, and moments of feeling well and feeling accepted. And I think those are pretty, those would be the same things most of us would say. Then, of course, it's very subjective things too, on top of that to make people individuals. But the connection is the thing, the sense of connection and feeling secure within the connections and within the environment, I believe, are the top. Okay, next slide. Can I have the next slide, please? Okay. During COVID, of course, connection was one of the big things, as Carol pointed out, that was lacking for people. So the crisis in care today, talking about the situation in long-term care today in BC, we started off with COVID, where the pandemic revealed so many different structural and system issues. But if, like me, you've been in the business since well into the 80s, or mid 80s, you know that most of those issues are long-standing. They were just revealed to the public. Long-term care is somewhat of a closed system. People don't go in there unless they're working there or have a family member. There are some volunteers, some community, but lots of people actually avoid long-term care facilities because they don't like what they stand for in their own lives. I think the need for action is urgent and remains urgent. that conditions are actually worse since the pandemic, sometimes because of unintended consequences of decisions that were made during the pandemic. I'm thinking about the staffing. We made some good decisions about staffing in BC, but then there was also a lot of attrition, a lot of moving around. For example, there's still people who are short-term staff. There is still short staffing in a lot of facilities. The other thing I would mention is about the positioning of families. You know, families really suffered along with residents during the COVID, worst times of COVID when there were full lockdowns, but that hasn't changed for a lot of facilities. There's still very rigid visiting criteria. So I think some of some things definitely were exacerbated. Many things were exacerbated, but it wasn't like it was a great place to be or to work prior to COVID. Next slide, please. Okay, I kind of organized this slide to think about, across the spectrum of the continuum of care, thinking about home support specifically, and then also in long-term care. As Carol talked about, there's a precarious, marginalized workforce that's inadequately supported. And by that, I mean in training and sick time and benefits and labor law and so forth, as well as mental health needs now. There's also the task focus in long-term care, which makes it very difficult for the staff to use the skills that they have, that it's more of an efficiency basis. There's not enough staff in long-term care, and there hasn't been for many, many years for the needs of the residents. And I believe it was Carol that pointed out that the needs have changed a lot over the last number of years, but the staffing hasn't, either in the community or in the facilities. The lack of allied health care, or the requirement for allied health care providers, social workers, dietitians are generally in facility, they have to be, but social work, physio, OT, those aren't. And so what you get is some facilities with none of those allied professionals, a lack of palliative care support for the staff or training for the staff, and also other mental health consultants availability to staff. So you don't only have not enough staff, you don't have the right kind of mix for the needs of the residents. The way families were positioned during COVID, I mentioned, but generally families feel fairly powerless within the system. They're the ones in need, they don't have the information they need, there are great demands on them. And certainly in long-term care, people have the idea that if they complain too much, that perhaps their family member will be targeted. Funding resources haven't kept pace with increasing care needs across the system. The last 20 years have really seen a decimation of, I guess I would say, labor conditions and therefore staffing. One of the things is in long-term care that caused, as part of the COVID thing that came to light, is people are paid very different amounts of money in long-term care. We have the issue of them being part-time and having to piecemeal a job between facilities, but also some facilities were paying far, far less than other facilities, which creates, again, an opportunity, well, not an opportunity, but it creates people moving around quite a bit where they can. A big use of casuals as well. A lot of this comes from business practices where profit is necessary to the business, and therefore to make that profit, really it's the food, it's the staffing. There's not many other places to make a profit when you all get the same amount of money from the government for the number of people you have. In terms of long-term care, again, through COVID, we saw how inadequate the physical environment is, and also the level of equipment available. This is long-standing. That, for instance, commodes, having to share a commode, one commode on a wing, and somebody needs it, somebody else has to wait, Wheelchairs, same thing, not necessarily available when people need them. The physical environment itself, we've talked about the 2 beds and the 4 beds, but even the institutional environment in itself isn't conducive to feeling at home. I'm talking about the long corridors, the lighting levels, the noise levels, those kinds of things that are long-standing systems issues. Quality of care and life are inadequately monitored. One of the things ARC did was review the licensing standards and also the accreditation standards, and found that really they don't focus on quality of life. The licensing in particular has virtually nothing there about care. They're more about the physical building and operations. And yet they're the ones that people complain to. They are the avenue for complaints. There are quality of care measures in Australia that are being used that we could build on, and quality of life actually integrated. But I think the quality of, just to illustrate this actually, Retirement Concepts is a for-profit corporation that operates quite a few facilities in British Columbia. Prior to COVID, 4 of them were put under administration. And all of those facilities, or possibly 3 out of 4, had been accredited just 2 or 3 months prior to going under administration. I think the other thing I would mention about this too is the number of complaints that had happened through licensing and also the patient quality office, and hadn't resulted in these places being put under administration. In fact, it was the families, the voice of the families, which are often not heard. Okay, enforcement and penalties for licensing infractions are lacking. So even if a facility does have infractions, there aren't really any meaningful penalties or enforcement of those infractions. So we don't have good standards and we don't have good monitoring. And then finally, as most of you will be familiar with, 1 Billion Reasons to Care that Isabel McKenzie, the seniors advocate, prepared, there's a lack of accountability for public funds used, public funds that are actually allocated for care. And in the facilities that were put under administration, that was one of the issues, was the reporting, the discrepancy between the reporting of the staff, the actual staff were there, and then the staffing model that they were supposed to be following. So there needs to be much more transparency and accountability. Next slide. Okay, and why is it like this? Well, Carol already said, and it's true, it's values. It really is about what we want for our older adults, what we want for people in general. We do have this workforce that's gendered and racialized, and informal caregivers are largely female, and so are the care receivers. So that's a big issue in itself. The racialized workforce, and many of them which are new immigrants, are also marginalized and somewhat vulnerable to poor labor practices. The status of the work, because it's women's work, often it's assumed that not much is needed in the way of skill. The conditions of work and the pay indicate that it's a low status occupation. So that's another aspect. When you have people like, when people are caring for people of low status, which old people have low status because of ageism and ableism, then you also, that status transfers itself to the workers. So the workers have low status on that basis too. And of course, the issue of ageism, the issue of ableism is rampant in our society in general. And therefore, in long-term care, where many of the people, well, almost everybody is old and disabled in one way or the other. So again, a marginalized, vulnerable population and a voiceless population because they're in an institution which is closed, generally speaking, to the public. And certainly unless you have somebody in there or you're a volunteer. And because of ageism too, and people's denial perhaps of their own aging and the fear of the future, people don't like going in there and seeing those sick people. They don't like going in there and seeing cognitively impaired people. We also have a medical model, which is hierarchical, and actually, even though the medical aspect is less than the functional aspect, or perhaps the social or the emotional or the social and emotional sort of needs of people, we still have a medical model that prioritizes nursing and medical care over social emotional care. Thinking about during COVID, the essential workers, it was quite a while before essential workers were designated. And then it was only for things like eating, or helping in some physical fashion with a family member that you might have been going in every day to help with care, every day to feed. that was the only way it was defined. The social needs and the emotional needs, the isolation, weren't taken into account. And finally, the paternalism. And the paternalism is during COVID too, in a way, the decisions that were made, the public health decisions that were made about long-term care, in some way were paternalistic. Family members had no say in them. And there was a really good article by some ethicists really arguing that the whole decision, the public health decision about long-term care and the lockdowns kept long-term, was really about keeping long-term care people out of hospital so the system didn't break down. And it was a huge sacrifice that's gone unacknowledged on the part of families and long-term care residents during that time. So those are some of the kinds of structural issues that have led us to the place that we are and where we've been for quite some time. And of course, the other piece is political will, political attitudes, how we value people in general. Okay, next slide. So what we need is a paradigm shift from an institutional medical model of care to a more humane and person-centered relational model, where care is provided by an adequate number of well-supported staff empowered to facilitate quality of life and human rights, and where families are partners in care. And just thinking about this paradigm shift needs to be in our thinking. And if we had that paradigm shift in our thinking, that would lead to a different kind of physical setup, different kinds of operation, different cultures in long-term care that would be supported, and many other aspects would fall from this. One of the things is, in a less hierarchical environment where staff were more valued, what you would have is them empowered to use the skills and the training they have to accommodate resident needs, to adapt to residents' needs, rather than to be task focused and efficiency based. This would apply in the community as well. People would be able to adjust, and these are the people who know the residents best, would be able to adjust to the needs of the resident and not be quite so constrained by the business model, really, that is, and the techno model that is driving care. And in terms of the families as partners in care, I mean, I think families have really lost trust in the system entirely. They're very traumatized by what's happened to them. And they certainly don't feel like partners in care. They feel very much like outsiders, and that voiceless as the resident that they're related to, and also unable to act on that person's behalf. So really traumatizing for families, definitely not partners. Next slide, please. What that has led to, though, in BC is there's been a push quite some time for family councils to be independent and supported and mandated by the ministry. And that has really taken off. There's been a provincial association formed and regional associations formed. So we may see some kind of change in that direction soon, we hope. So reformed long-term care system would have culture and leadership that facilitates quality of life. That's how staff would be deployed. It would be the scheduling of staff for continuity, being the main focus. It would be allowing staff to work to the full scope, allowing staff to use their training to be empowered to adjust to the residents, to accommodate, to be creative. It would be less hierarchical. It would be relational based, and it would also be certainly individualized. A greater emphasis on social, emotional, and relational care. Not to throw out the baby with the bathwater. You do need medical and nursing care. And, nurses also provide emotional, social, and relational care, and meaning the medical side of things. You would need all that. You still need to have the care, people bathed and so forth, but a greater emphasis on these other aspects. A workforce that is well educated and supported, talking about their mental health needs, trauma-informed mental health care for them, and so forth. Quality of care and quality of life standards that are effectively monitored and enforced with penalties, really important. In Australia, they have quality of life, I'm not sure what they call them, quality of life monitors. It's a little bit different. They have a set of quality care, quality of life standards, and different people then licensing to to go in and assess those. A really, really interesting and complex and looking very positive system that came out only recently. Mandated and supported independent family councils who would have a place in policy development, why not in staffing, in the hiring of staff, and who would be the canaries. What do they call that? The canaries in the mine, the ones who actually point out things first and feel that they have a voice and that voice is heard, so they actually interact with management in a non-confrontational way on both sides. A less institutional physical environment. Carol spoke about the different models, and if we could imagine them, we could do them. Part of the issue is that we can't imagine making those changes. They seem huge. From the big institutional buildings, how do we get to those little communities? How do we get to the small places? But they certainly have their benefits. And increased accountability for care and spending public dollars. Again, going back to the business model and profit, the need for profit in some facilities, and where does that come from, really needs to be examined. Next slide, please. So just thinking about, again, that we actually have to think about long-term care in the full context. ARC is interested in long-term care again, because if ever anything is going to change, it's when people in the public are actually aware and concerned about what goes on in there. But it is a continuum, as Carol pointed out too, in Alberta, I think it was Alberta, where they went very aggressively to aging in place. That has unintended consequences for the people who are living in the community. And for their caregivers, for sure. 94% of those 65 plus live in the community, and at 72% of seniors live in their own homes, 10% live in retirement residence or assisted living, and 17% in LTC. So actually, that's another part of what makes this difficult is there's not very many people in long-term care across the province, and with that, not very many family members. So it is a population that's fairly easy to ignore. Again, why it's so important to engage the public. So could I get you to the next slide, please? So just thinking though about the quality of life in the community, and here we have service in silos in many ways. People complain about too many different workers. You can have many workers coming in at the same time and the same day for different purposes. On the other hand, you may not have enough workers because not enough hours of service are provided. But people with a lot of needs often complain about 3-4 workers, different workers all the time. The workers lack flexibility. This gets back to the task orientation and the idea that they have set amount of time. They can only use that time for set things. So even though it might make common sense, if you're preparing a meal, to clean up after the meal, to help the person with the meal, to do a number of things around that meal, help maybe with the listing the groceries that might be needed for the next meals. Some of those things aren't part of that job or part of that task, or somebody will come in and their job is to bathe, or their job is to do something else. And there's a need that the person has in their home, but they're not allowed to address that. Or the caregiver has a need. They're not making the caregiver food, they're making the resident food, or not the resident, the citizen food. So that lack of flexibility and inability to respond to different situations, to accommodate different situations, for the workers really to use their common sense, if you like, and what they know about the person is lacking. The insufficient hours of service. I think one of the things in Isabel Mackenzie's report on the system overall was saying how that in the last, a large proportion of people who come into long-term care hadn't had any home support at all in the previous 90 days. The lack of support for informal caregivers who are doing a huge amount of the work in the home as part, and this could be somebody, a spouse, an older spouse, or it could be a daughter who doesn't even live in the same city, or certainly not in the same home, but the lack of support for the expectation of what informal caregivers do, and the lack of support, and this particularly emotional support and social support for what they do, besides the concrete, is a major issue in the community. Quality of life during COVID in the community, we know much less about people's experiences, I think, in community than we do in long-term care. But certainly loneliness and social isolation at the best of times, especially for those people living alone and relying on home support. The reasons people are living alone, aside from widowhood and singleton and all those other kinds of things, is often that one partner could be in facility. But people are lonely because they may not be able to connect with people they know out in the community because of the transportation issues or because of geographic issues. They live at the top of the hill, and they can't get down to the bus stop. I mean, there's so many different reasons, the resources that they have available to them in terms of money, for example. So at the best of times, people can become lonely and socially isolated. The fact that the home care workers and the Better at Home and the volunteers are coming in to do specific tasks, but not really to befriend, can be also accentuate the experience of feeling lonely too, as well as the loss of privacy for people who live alone and for couples. The number of people coming in and out of the home can feel very invasive. The caregiver distress, of course, from what they're expected to do, the isolation magnified hugely during COVID, and also the lack of training, if you like, or available to them easily, or that they don't take advantage of, and therefore have difficulty in managing someone at home, especially with dementia, can be huge. And the isolation they experience themselves as they are confined to home with the person they're caring for. And early admission to long-term care can certainly result when families are very stressed, or when families are just not getting a sufficient amount of care that they need at home. They might be able to stay at home longer, but they might not, given more care. And there's been quite a few studies done on the cost of home, and I think Dr. Sinat's group is one of them, looking at the cost of home care versus the cost of long-term care. That if we gave the same amount of money that we pay out for long-term care to someone in the community, that would make a difference for the community-based people, but we don't spend as much on them as we do on those in care, and yet sometimes they have very high needs. Next one, please. So if we were going to facilitate quality of life in the community, we would need to look at the whole picture and the totality of what's required to live independently. We need wraparound services. So when people go in to help someone with one thing and they see another need, they can provide for it. Up until the 90s, home support provided housekeeping services and did the kinds of things that needed to be done in order to make the home a functioning home for the person. The other thing is that the Veterans Affairs, for example, they have augmented services for their clientele, which include things like yard work, and maintenance, home maintenance that isn't provided routinely at all for other seniors, and yet are part of what makes the home a place to live in, makes you feel secure, and especially if you've been a person who's looked after your home, kept it clean, looked after your yard, it's very upsetting to see things deteriorate around you. So that's something that could be looked at as that whole picture. And of course, things like ordering the groceries, bringing in the groceries, Meals on Wheels, all of these things are separate services that need better integration. Expanding the scope of home support services, for example, to include the social, the emotional, and to be able to spend the time with people and to do the things that need to be done, not to be so rigidly task-oriented. Redesigning care plans and roles that enable workers to respond flexibly to needs and to build relationships could be important. That would certainly support quality of life. Empowering the clients and the families with needed information. Lots of times families don't know and aren't told what their entitlements are. They're not told, they're given so much home support. You get 2 hours a day or 2 hours a week, but they're not told that it could go up to, with the right criteria, if they met the criteria, to this amount, that they have a greater entitlement than perhaps what they're offered. And like in BC, we have a CECL program where people are allowed to, are given the money to manage their care, employ the person, and manage the care of the care recipient themselves, or the care recipient in some cases can also receive the money, but very, very, very few people know about that. It's not made public. So partly it's giving people that information. The other kind of information they need is, of course, what the Alzheimer's Society and First Link is providing, is what resources in the case of dementia are available to people and how to access them. And this needs to be done at the beginning and also along the way, because people sometimes are only interested in the information they need immediately and then forget about it. And none of this brings forward the idea of culture either, you know, that you have different cultural groups out there who need to have access to people in their own cultural community, language community as well, that we haven't really built into our system. And finally, recognizing and addressing the needs of caregivers would make a big difference in terms of their quality of life, as well as the quality of life of the resident or the client at home, and better training and compensation strategy to attract home care workers and to keep them, you know, so that they stay in the job. Currently in BC, the home care workers are paid less than the long-term care workers since their wages have been leveled. And also many of them are only part-time. I think it's about 50% are only part-time, and not necessarily by choice. In fact, not by choice. And they don't get paid to go from one place to another. And they're running all the time. And they need to provide their own cars for this poorer pay as well. So we certainly need better training and compensation for people to manage the complexity and to be willing to take these jobs and to stay in these jobs. And it comes back to status again, to making these jobs more attractive and more higher status, which would come perhaps with some of the registry gaps filled that the previous speaker was talking about. Next slide. Okay, so coming back full circle to long-term care, we fully understand that long-term care is part of the continuum, that if you only address one part of the system, you're really likely robbing it, or you're creating unintended effects and negative effects on the other side of the system. So we believe that addressing long-term care means taking into account the entire context and thinking about those pinch points. At the same time, as I said earlier, we definitely believe that if ever there's going to be a time where we could make changes, meaningful changes in long-term care that would support workers and improve quality of life for residents, it has to be now. We have an opportunity. That is one of the opportunities, as people have said, that COVID has presented. So our ask at the moment, we have been meeting regularly with the Parliamentary Secretary for Seniors and Long-Term Care. And I have to say too, that the government has made a lot of changes along the way since the beginning of COVID. Someone talked about the one site rule, which has been a little bit modified, but it's still basically the same idea. The leveling of wages, as I mentioned, some places paid far less than other places. The leveling of wages to the government level. And also things like creating the healthcare aid program and putting incentives in place for people, increasing the number of seats for RNs, training of RNs, and doing something, I'm not sure what, facilitating accreditation of foreign trained nurses. And also, I guess the other thing that they're doing too is, I know, looking at family councils and how family councils can be supported. Nothing out on that one yet, but the interest is there, so that's great. So they've done a lot of stuff, but it is piecemeal. And most of it has been to support the precarious workforce, which is fine, but it still remains somewhat piecemeal. What we're now asking, our current ask for the provincial government, is an action plan. We want a provincial action plan to implement the recommendations that are made in the ARC report. Now, are building on those recommendations, which take into account things like standards, licensing, staffing numbers, staffing mix, and quite a broad range of things, family, voice for families and so forth. But the idea would be to create a plan that builds on those ideas. And I think the ideas are the recommendations we've made would be shared by Restoring Trust, a document that Carol led, and many other documents that have come out. They're not rocket science. We've known for a long time what needs to be done. We just haven't done it. So we want an action plan at the provincial level, because as somebody pointed out much earlier, the province, the government has the money. The government is the only one that can actually make some of the changes that need to be made and that can fund the things that need to be funded. So we're asking for this group to be multi-stakeholder. We want it to have, we want residents there, we want families there, we want allied professionals, we want across facility operators and so on to be engaged in this action in an advisory forum that would actually lead this change. And we want to structure it to ensure that all voices are heard and part of decision making. We also have unions on that, I should mention too, in terms of our multi-sectoral task force, as well as professional associations, people who are very interested and in the care of residents in long-term care without hidden agendas. By that I mean profit making. Provincial funding and rollout across the province is what we're wanting as well. So we have put a proposal into the provincial government asking them to appoint an advisory forum for long-term care reform. They've done these kinds of advisory forums before, so it's not unfamiliar to them. They've done them in a poverty reduction planning, actually. So this is something that we are meeting with them on June 15th, actually, to talk about. Could I have the next slide?
1 minute,
Yep.
Penny.
Okay, last slide.
Or last.
So what does it take to reform? Okay, the values, principle-based policy for which the government is accountable for creating a system that's based on these values, principles, and so forth is really important. Strengthening of the entire continuum, more money, so standards that we talked about earlier can actually be implemented. More staff, appropriate staff, consistent, higher wages, increase their status, wage parity across sector, and ultimately, and I would also say appropriate monitoring and enforcement of standards for quality of life, standards for the national standards that are just coming out and so forth. But ultimately it takes political will, and that takes public demand. So what we are doing, last slide, what we were doing is leveraging our supporting organizations. We've got about 45 of them that between them have over 350,000 members. They're unions, family councils, academia, including SFU, also the allied professionals, professional associations, and seniors organizations support the recommendations that we've made. We want to develop a strategy to mobilize the public to provide a provincial action plan for reformed LTC. And that is our goal at the moment. That's the strategy we're developing. We've done piecemeal things like MLA letter writing, petitions, and so forth. But now we are aiming for a full-blown comprehensive strategy and preparing for the next election. Thank you. On the last slide, you'll see where the ARC report is. I think you have that available to you. You could look at that ARC report. And you'll also see there's a tremendous media list over 100 pages long that we've kept track of all the media during COVID that might be of interest to people. So thank you very much.